introduction, and I'm really sorry. Suddenly I have this sudden back pain problem, just from the day before. So it's difficult for me to join you physically there. But I see that all the meeting is going very well. Tremendous speakers and very nice interaction. I watch you online. So I hope there'll be nothing negative for my online presentation, Transcatheter mitral valve intervention, a 20-year journey, and the disclosures and the heart team were working together at the year. So when we're talking about transcatheter mitral valve interventions, we're talking about transcatheter mitral valve repair, which as we all know comes to the form of clipping the mitral valve that we call edge-to-edge repair, but as I said earlier, probably we should change that and call it body-to-body repair, because we're not just bringing together the edges of the leaflets, but up to 12 millimeters of the body of the leaflets we bring together. Then we have annuloplasty, although licensed, used very little so far, but perhaps things will change in the future, we'll see. And then we have the transcatheter mitral valve replacement, which is very easy in brackets when we already have a valve or a ring there. Much more difficult, as Professor Mark said earlier, when we have MAC. And finally, the transcatheter mitral valve in native valve without stenosis that is coming and is developing. So we're talking a lot about the clipping today. The mitral valve is considered a solid, well-established therapy and very widely used. But let's see the real results, not those coming from the study, but those studies from the trials, but those coming from the real clinical practice. And this is the latest data from the TVT registry, 60,000 interventions. As you can see, elderly patient average age is 82 years old, STS score close to 5%. And as you can see, most of these patients were DMR patients because the FMR approval in the US came just very lately. So that's why the majority is DMR, but there's also a considerable number, like 30% probably, of FMR. And so what's the 30-day mortality of this procedure in real life? It's not 0%, as many of us believe. It's 2.66%. So it's not zero. It's very low, but it's not zero. And then we have all the rest that are very rare. So it's generally a benign procedure, low 30-day mortality. And we have to consider also the population that's undergoing this procedure, which is elderly and high-risk population. Improvement in the symptoms, no doubt about it. As you can see here, New York Heart Association class, significant improvement. And what happens to the MR? We have MR reduction, as you can see here, at 30 days, that is 97% 0 to 2 degrees and 77% 0 or 1 degree. So the second is considered to be a real success, to have 0 or 1 degree. And in reality, we have 77% post-procedure, but watch how it falls almost 10% at 30 days. So we lose some success just within the very first month after the procedure. And this is that we see in many studies. So are we satisfied with this 65%? I don't think that anybody of us would be satisfied with this outcome. That's why there's still studies, investigation, and new devices in this field. This is the reduction of the success if we also take into account a mitral gradient below 10 millimeters of mercury or MR2 or below. So it's 89% to 30 days. So if we go to MR1 or below, this will automatically go to 70-something%. And what happens through the years? Do we have an improvement in the results? Yes, absolutely. We have an improvement. As you can see here, for MR success, as defined earlier, it goes from 81% to 92%. And this is for grade 2 or below. So deduct 10% if you want to see the grade 1 or below. So certainly there is an improvement. What happens to those who have a successful procedure versus those that have a successful procedure is very obvious that the mortality of the latter is very bleak and very high compared to those that have a successful procedure. And of course, heart failure hospitalization readmissions are falling down when you have a successful TEER procedure, and reintervention is really very low when you're successful at the beginning. As you can see, 2% compared to 13% for those that were not successful at the beginning. Is there any tool of living moderate MR like we do? Yes, there is. As you can see here, even moderate MR have worse outcome than those with mild MR. That's why we strive for the mild MR in the majority of our patients. And if we put into boxes all the possibilities here, if we go to this really much desired population outcome, we want to have mild MR and a gradient of below 5%. This is just 52% of the patients in the TVT registry. So we are all enthusiastic about this treatment, but we shouldn't forget this data coming from real life. And now, in contrast to this data, we have the data from the studies. This is the latest study for the Gen 4 mitral clip, the Expand G4, and we see here a success rate of 89%, MR or below, 1 or below the 30 days. Certainly, there is an improvement in the technology, and now this generation 4 is expected to provide better results than what we saw in the TVST registry. And similarly, with the Pascal device, the other device we have to use, we have similar results at 88% success, MR1 or below. But even in these studies, if we go and get the difficult anatomies, the risk of inadequate MR reduction, as we can see here, all the difficult anatomies, and then we see that the success rate falls like 15%, from 90% to 75%. So this is something we should take a note. Similar in the CLASP 2D trial that compared the Pascal and the mitral clip in DMR patients. There was a Pascal 2D registry, patients that thought to have complex anatomy and were not included in the randomized trial, but they went into this registry. And these are all the difficult anatomies that we frequently meet. And here again, you see the success rate falls from 83% to 56% for these patients. So TEER is here, we all use it, but we should remember that we can't get the best results for all patients, especially for difficult anatomies. Let's move now to the transcatheter mitral valve replacement. Things are relatively easy when we have a mitral, a biprosthetic mitral valve there that is degenerated. And as you can see, we started doing this procedure back in 2012. So it's like 12 years now we're using this procedure. Initially, we're going transapically, like in this first case, that we had a very good result after the positioning of the very old, as you can see, Sapien XT there. And this is the first case we did 2 years after with a ring, again, transapical valve and ring. You can see the old Sapien XT there, 29 millimeters. And again, we're very happy with the results when we have a valve or a ring. But of course, the goal was to move to transfemoral for all these cases to avoid all the mortality risk that is associated with the transapical approach. And this was the first case we did from transfemoral approach from the leg in 2019 or 2018, if I remember. And you can see the regurgitation. There is a ring there, as you can see, the septal dilatation. And then we go with a Sapien valve and we inflated. You need to master the positioning of the valve here to put it in the right position so you avoid to have any paravalvular leak and the need for a second valve if something goes wrong. And here is how it appeared after the positioning. Again, very good result. What we measured from before, we learned with the CT scan is the neo LVOT that we're going to have after simulation of the positioning of the valve. This is another case. Generally, if we have a neo LVOT of 1.7, 1.8 square centimeters and above, we're happy. Again, another valve in valve. And another one, again, the neo LVOT was 2.2 here. This is a valve in a ring. So this is a sort of like a common procedure nowadays and makes things easier in most cases that we have a degenerated valve or a ring with acceptable result, but requires a lot of screening. And this is a very complicated case that I was involved in, done at St. Lucas Hospital. I find it very interesting. That's why I'd like to show you. It was a MAC case, as you can see here. That was initially treated with a hybrid approach, so debridement of the anterior leaflet, and then they implanted a sapien valve there with very good initial results. A very minimal paravalvular leak. Then 15 days after, the patient still in the hospital had severe aortic regurgitation from a degenerated aortic valve. I don't know if that was the result of the operation of the mitral valve, if it was provoked from that, but they had to treat it. So they implanted a sapien valve, evolute valve with a good result. But it was not over because 3 days after that, the patient had severe hemolysis. As you can see here, severe paravalvular now leak, and probably the sapien valve, despite the sutures, moved backwards. So at that point, I was called for some help, and we decided to go for a valve in the mitral valve. And this is a procedure, septostomy, and going with a sapien 29, the big one, in a more ventricular position. And after doing this procedure, the patient improved, and she was able to be discharged from the hospital. This was the final result. So, and this was the appearance of a CT scan with 2 valves in the mitral valve and 2 valves in the aortic valve. Very interesting case. And that's why, as I explained earlier, we need something else for the mitral valve, because with TEER, we're not getting always an optimal result. And we have cases that we need to eliminate the tricuspid regurgitation. And for those, we have the TMVR. It's outside and discussed and analyzed and studied for like 15 or even 20 years now, but we haven't seen a device coming successfully into the market. Tendyne is the only one approved so far, but despite being in the market for quite a few years now, the numbers are very low. The study is still ongoing after so many years, the SUMMIT study, comparing Tendyne with MitraClip. There is also a MAC cohort that is finished, but the study, I'm not sure if it will ever finish. The reason is that the screen fail is, as you can see, 70% mainly for neo-LVOT obstruction or sizing. The other valve that we studied is the Medtronic Intrepid. We had our own share of experience here. This is the first implantation, transapical implantation we did of this valve many years ago. It's more than 8 years ago. And you see the expansion, the flaring, and the positioning, the delivery. And this patient is still alive. So I think it's the longest alive patient with Intrepid valve today. And last year we did this transesophageal echo. You see the functioning of the valve so many years after the implantation is doing fine, very nice imaging. So this is a proof that this valve, once it's implanted and the patient has a good life expectancy, it stands up to its work so many years after. Very happy to see this, and I think it's a testament that we should keep striving to find transcatheter mitral valve solutions. This valve is undergoing a whole study. Dr. Mark is the PI, so he knows most than all of us Initially, it was the 35 transfemoral device, but now I think they have available the 29 French transfemoral device and also one additional size, the 54 millimeters, to have more patients included. This is another valve, the M3, the SAPIEN M3 valve, that basically is two systems coming together, the SAPIEN M3 dock, and then the SAPIEN valve that goes and is implanted, the very well-known SAPIEN valve within the dome. I'll show you just this video here just to understand how it is done. So this is very similar to the Pascal device alignment. We have the two flexible guides one into the other, and then the dock is advanced initially as a guide catheter that circles around both leaflets, which means that the leaflets are held by the dock, and then once the dock is released, there is a holder, as you can see, into the base of the floor of the left atrium, and also this pillow to prevent PVL from the posterior leaflet, and then the SAPIEN is implanted. So this is the study of this valve is the ENCIRCLE, and it's the only one that managed to finish in time. And actually, it will be reported later this year at TCT, and probably the valve will be the first one licensed for transeptal valve for mitral valve later this year, provided that the trial results will be good. And this is the main study with 300 patients. They also had a failed T registry with 100 patients and a MAC registry with 100 patients. And here, as you see, the dock deployment and the valve implant, how it looks within the dock after the implantation. And of course, with the other one that is in study is the Alta valve. We've heard earlier today that there is 70 implantations worldwide now. This is a very large device. It basically, it's like a ball within the right atrium, the left atrium. It has certain advantages, but also disadvantages. The results appear to be good. They have very good reduction or elimination, but the 30-day mortality is around 8%, still high. And the main problem with all these valves is the LVOT obstruction. This is the main reason that the patients are rejected from these studies. We learned a lot about how to predict the new LVOT. Initially, we're getting at the end of the systole, but we know that 75% of the blood is coming out in the first 20%. So now we measure the 20% of the circle to predict, and so this makes more patients acceptable for this procedure. And for those that the risk is very high, we have all the lampoon flavors before the implantation that is personally tried so far, and unless it becomes more user-friendly and accessible to us, I don't think it will be widely used. Another approach is the pre-empty alcohol septal ablation. This has been proved to work, but it is linked with considerable mortality and also considerable need to use a pacemaker. And the final question is, if we implant a valve, how often we have to close the iatrogenic ASD? And once you close it, there's no way to go back. And if this valve degenerates and you need a valve in valve, then this is lost. So the question is, how often we have to do that? We get some information from this SAPIEN mitral valve in valve registry with almost 80 patients. And we see here that the closure rate was 11%, 10 to 11%. And so the SAPIEN is around 20 French, 22 French, similar to the M3 valve that will be 22 French. So we can predict that the need for the closure will be around 10% when we use this valve. And with this, I would like to thank you for your
Great, thank you very much, Kostas, for your nice presentation indeed, but also for your huge contribution to Hellenic and European interventional cardiology. Any comments from the audience? Because, as we said before, we are running very late. Just a brief, naive question. Do you expect in the next 10 years to see the trajectory of mitral valve replacement following more or less the same pattern like TAVI? No, I'm sure not.
Clearly no, because there are many difficulties as we have seen and we have realized over the past 10 years in designing a device that will be good for the mitral valve. The reason is the mitral valve is much more complex than the aortic valve. I believe that because the engineers are so clever, they will come up with solutions to all these problems, and at the end, we'll have not just one, but multiple technologies available. The question is what the range of pathologies, of anatomies will be amenable for each of those valves. We need, because if one valve is good only like for 30% of the cases, then I think it would be very difficult to be successful commercially.
I think TAVI has been successful because you replicate something we do as surgeons that has been successful. Most of our transcatheter mitral stuff does not really replicate what we do very well. But one of these days we're going to be talking about neopapillary muscles and cords, and you'll be repairing mitral valves just like I do with a neopapillary muscle and a cord. And when that happens, that'll take off like TAVR. You'll see it in your lifetime. I may be retired by then, but it's going to be exciting to see.
Okay.
Great session.
Great. Thank you very much.